speaking on the issue of pediatric imaging. And now we will shift to the next presenter, and I'm very pleased to present Dr. Ola Halmperg, who will speak to us about patient exposure from recurrent imaging. Dr. Ola is the head of the Radiation Protection of Patients Unit at the International Atomic Energy Agency, known IAEA, in Vienna, Austria, an organization with the United Nations family, and in fact, one of our close collaborators we work with in WHO. He is a medical physicist from Sweden with radiotherapy experience from Skane University Hospital, Malmö, Sweden, St. Luke's Hospital in Dublin, Ireland, and the Netherlands Cancer Institute in Amsterdam. Prior to his appointment to the IAEA in 2008, he was the chief physicist at the Copenhagen University Hospital in Denmark. Dr. Ola is the co-founder of the Radiation Oncology Safety Information System, an international voluntary safety reporting system for radiotherapy, and he has also participated as a member for the International Commission on Radiological Protection on Prevention of Accidental Exposure from new external beam radiation therapy technologies. He has published scientific papers, various scientific papers in The Lancet. He's a course director for ESRO, or radiotherapy treatment planning. He has lectured on prevention of accidents in radiotherapy in different countries. He has participated in different international conferences, and he has supported in the Bonn Call for Action that was issued in 2012. And over to you, Dr. Ola. The floor is yours.
Thank you so much. I would actually just like to start off by saying, of course, thank you to the organizers for their invitation to the IAEA, but a special thank you to Dina for putting radiation protection on the agenda for a radiology conference. And we know it's not the most popular of topics, but you always hold it high because of its importance. So thank you so much for that. Also, I want to acknowledge here that a lot of the work in the IAEA in this area on recurrent imaging is done by my colleague Zhenya Vasileva, who is currently, I believe, in Kyrgyzstan and working in the field there. So that said, we all know, of course, and we see in so many of the presentations here these few days at the conference and in our daily work, that medical imaging procedures using ionizing radiation are essential and that the benefits are undebatable. But we also know that there are evidence for, less well justified and not properly optimized radiological procedures. And these have triggered a number of worldwide actions for strengthening radiation protection of patients. For example, through the International Action Plan on Radiation Protection of Patients and the Bonn Call for Action. There are a number of standards and recommendations in this area, such as we see here from ICRP, from a number of co-sponsors of the IAEA safety standards, the international basic safety standards, and we all know some of the facts from here. For example, that dose limits don't apply to medical exposure of patients. If you had dose limits for patients, you would essentially limit the benefits if they're properly justified medical exposures. There are many efforts towards improved justification and optimization of radiation protection for single patient exposures. And many of the dose reductions that we've seen recently have been due to, I think it's fair to say, to technological developments, and also in some way to the improved appropriateness or improved application of justification and the optimization of imaging procedures. And the trend that we see now is a slowing down of the increase of collective dose from imaging as evidenced from the recently published UNSCARE numbers. We wouldn't be here if there wasn't any radiation risk for patients. But when it's properly justified and optimized, radiation doses and related risks from a single procedure is probably in the region of negligible to low, according to ICRP. But if multiple procedures are performed to the same individual, you can reach and exceed a cumulative effective dose of 100 millisieverts. And then you come up into an area where the risk is classified as moderate, according to ICRP. And there is stronger existing evidence from epidemiology for an increased cancer risk above 100 millisieverts. So these multiple procedures is what we're talking about now in this particular talk here. And it's also called multiple imaging, frequent imaging. The patients I've heard called frequent flyers, for example. And it's not fully new. There's been many articles published over the last 2 decades on this issue. There are some studies on who are the patients who might need this recurrent imaging. And for example, we have patients with malignancies, with renal colic, cardiovascular diseases, pulmonary diseases, inflammatory bowel disease, or emergency department patients. And you can read more details on this in a review article published through the IAEA in the British Journal of Radiology. In this review article, we looked at 20 published studies, or more than 20 published studies since 2009, focused on patients with high cumulative effective dose. Half of them are recent, some of them are motivated by 2 technical meetings that we had in the IAEA on this topic. In total, these studies contain a total number of over 11 million patients, the majority from the US and from Europe, very few from Asia and Africa, no data from Latin America. And you can see here the period of retrospective evaluation of exposure history. It's between 1 and 22 years. Most frequently, range is 3 to 5 years. And most of this of these population-based studies are limited to CT. Some of the key facts that came out in this review and was highlighted in this review is that a conservative estimate is that close to 1 million patients globally, or 0.64% of all patients who undergo CT exam, accumulate annually more than 100 millisieverts. So 1 million patients, 0.64% doesn't sound so much, but actually 1 million persons is, gives a more of an impact as a number, I think. 2.5 million patients reach 100 millisieverts in a 5-year period, and it was even seen from a recent, more recent study in France that these numbers might be underestimated. So who are these patients who require recurrent imaging? You might think that it's all older patients, but actually a substantial number of the patients was seen to be under the age of 50. Pediatric patients, more studies are needed. Patients with no malignancy or with a cancer history that shows no active cancer is also a substantial fraction of these patients in the study. So the next question then becomes, what about the justification, the appropriateness of these patients with a high cumulative dose? Has it been seen to be justified or not? And there's, to my knowledge, only very few studies so far on this. One by Madan Rehani, who we will hear from later, showed that in a big, well-equipped clinic with a clinical decision support system, actually, yes, there was high appropriateness in the exposure of these patients. They were a very large majority properly justified. And there's been some other study also, but maybe not representative for the global picture of this. I think there's more analysis needed on this topic of clinical appropriateness of these patients with high CED, and also is the guidance sufficient when you're using imaging in management of patients with these particular clinical conditions where you might require serial imaging and a long period of follow-up. So there's more question marks here for them. So because there are still a number of gaps in the knowledge on this issue, the IAEA held 2 technical meetings on this topic, and in the second technical meeting we also launched a joint position statement together with 8 other organizations, and this was launched last year in May. And the purpose really is to guide the process so that patients with medical conditions which prompt more frequent imaging and procedures receive the needed medical care without undue exposure to ionizing radiation. And this position statement is by no means thought to come with ready solutions, but it's intended to prompt a greater dialogue on this topic, because in the radiation protection world in medicine, I think that we still need to figure out what to do with these patients. There were a number of actions in the joint position statement, and just summarized in a very high level way here on the slide, it's about that we need to gather more information on this topic. We need to assess the level of recurrent radiological imaging. We need to identify which clinical conditions where it's likely with this imaging that leads to a relatively high cumulative dose to the patient. And we also need to develop some methods and some strategies for radiological imaging for these clinical conditions that require recurrent imaging. Perhaps in the fourth bullet here, one thing that will impact or might impact the whole radiological protection system is do we need to look at the justification and appropriateness not of a single exposure of a patient only, but also if it's possible to predict that the patient will have an entire series of radiological procedures? Is that something that should be taken into account at justification? This is what needs to be discussed, I think, in the radiation protection community and with the medical community overall. And there are also other actions on monitoring radiation exposure, further reduced doses, customized imaging protocols, strengthen radiation protection education and training, and strengthen communication. So I'm just rounding off here now, and I started mentioning the radiation protection framework, how this may be impacting the framework with an increased knowledge that we have of all these patients who require recurrent imaging. There is currently a lacking consensus on how we should use dose information from the previous procedures. This is not an easy thing to figure out. How should we use that information, and if so, how should we use it? Because there is also concern that this might be misused and misinterpreted, that patients are stopped from having very beneficial procedures done, and that would be the worst situation, I think, if we end up in that. But the competence and awareness of users of dose information is paramount, and this is linked to the knowledge, education, training, and communication. But I think it's worth to keep in mind also what the ICRP says in its report 103, that annual doses rising towards 100 millisieverts will almost always justify the introduction of protective actions. So do we need to introduce some considerations of this in the radiation protection system, or do we stand worse consequences if we do that? So it's up for discussion, I think. So to conclude, the management of exposure of patients with medical conditions which prompt more frequent imaging procedures, they require additional considerations. The radiation protection perspective is only one, and it complements the clinical perspective. We need to look at this holistically. The risk to benefit analysis must also account holistically for all incidental and long-term benefits and risk for patients, their clinical history and specific needs. We can't look at this in isolation only. And looking at it more broadly is possibly a step towards the patient, more patient-centric healthcare. Thank you very much. Thank you. And I'm double tasking here because I'm also introducing our next speaker. It's Dr. Steve Ebdon-Jackson. And it says in the summary about him that his career spans over 40 years. And I was thinking back, and I think it's between 2 and 3 decades